Hello, I am Dr. Hussein Abdel Daim. I'm a consultant dermatologist in Mediclinic and Noor Hospital in Abu Dhabi. I have been working as a dermatologist for a long time, and it is really my pleasure today to share in this international webinar about experts' perspective on JAK inhibitors for the treatment of moderate to severe atopic dermatitis. This webinar is created with cooperation with Eli Lilly. Thank you for Eli Lilly for arranging such a webinar. During this webinar, we are going to hear from experts on what to consider when starting a patient with moderate to severe atopic dermatitis on the newly introduced JAK inhibitors. What are the safety considerations? How to start a patient on Olumient? How to start a patient on Veraceti? And what has been the patient feedback when using this Veraceti through case sharing from our guest speakers. Give me the chance and the pleasure and the honor to introduce our two speakers today. The first speaker will be Dr. Siri Kumar Grutu. Dr. Siri Kumar is working as a head of department at the Dermatology Center of Amber Clinic in Dubai and medical director of Joseph's Polyclinic in Al Karama, Dubai. Dr. Siri Kumar is a consultant dermatologist and venereologist trained in renowned medical schools of India, namely the Madras Medical College. Our second guest for today is Dr. Ahmed Amin. Dr. Ahmed Amin is a specialist dermatologist and venereologist in New Medical Center Specialty Hospital in Abu Dhabi. Dr. Amin participated in many clinical trials as a principal investigator in psoriasis, atopic dermatitis, and acne. Also, he published posters and abstracts in international conferences. After introducing my two guest speakers, it gives me the chance to start some questions for our two experts. Thank you, Dr. Siri Kumar and Dr. Ahmed Amin, for joining us today for the discussion. And let me start with this question. What are the challenges in treating patients with moderate to severe atopic dermatitis, and how does the arrival of the JAK inhibitors help address these challenges? Dr. Siri Kumar, please.
We are actually at a tipping point where we are able to offer our patients newer medications with our better understanding, and we are in a position to make our patients sleep better, have a better life, and actually have an outcome where their self-esteem and their self-confidence in their appearance and their ability to work and interact and have a quality life has actually undergone a paradigm shift. So it's indeed a pleasure. The challenges, of course, are how to reduce the itch, how to give a better sleep, how to reduce skin pain, how to improve the quality of life, how to improve the appearance, how to improve the self-confidence of a person. So almost on all of these, the arrival of the newer molecules, especially with the oral JAK inhibitors, we seem to be achieving or putting a tick on almost all these needs. And the safety of these molecules seem to be pretty good as far as the studies are concerned. And we are at a point where we can offer an oral molecule, which is easy to use, easy to monitor, and makes a huge difference in the quality of life of our patients. I'm sure this is a time that all of us are indeed praying for, and we seem to have reached a tipping point indeed.
Thank you, Dr. Siri Kumar, and I'm going to address the same question to Dr. Ahmed Amin.
Thank you, Dr. Hussein, for raising this question. And first of all, dear colleagues, it's a pleasure to be with Dr. Hussein and Dr. Siri Kumar in such scientific meetings. When we talk about the challenges in atopic dermatitis treatment, we know that we still have an unmet needs in atopic dermatitis treatment paradigm that we have it today. That's why we are looking for new molecules that may tighten this unmet needs that we have. If we go back to the pathogenesis of atopic dermatitis, we will come to know how difficult the process to control such a chronic disease with one medication or with one mechanism of action. If we have a look in this slide and see all these multiple key players which is implemented in pathogenesis of atopic dermatitis, we can see IL-31 have a role in itch, IL-4 and IL-13. In the chronic stage, we have an IL-17, we have an IL-22, interferon gamma. All these cytokines are implemented in the pathogenesis of atopic dermatitis, whatever is it acute stage or it's chronic stage. All the pharmaceutical companies will start to work in these key players individually through trying to block one of these cytokines, goaling that they may control the disease progression only by blocking these cytokines. And this is the concept of monoclonal antibodies or biologics in treatment of atopic dermatitis. We have some molecules working in IL-4 and 13, other molecules working only in IL-13, some ongoing trials for IL-31. So everybody thinking that by blocking this specific cytokine can control the disease progression. But other companies working in a different way through a broader level of blocking. And when we are talking about JAK-STAT pathway inhibition, we are talking about a different way of blocking that we can kill more than one bird with one stone only. And this is the concept of JAK-STAT inhibition. So all these cytokines will be broadly blocked by the JAK pathway inhibition. We are start to control IL-31, IL-13, IL-4, TSLP, IL-22, interferon gamma, and all these are considered a main key players in the pathogenesis of atopic dermatitis. So now we are tightening these challenges. We are reducing the unmet according to our understanding of the pathogenesis of atopic dermatitis. Once we are introducing a new molecule in the market, we are able to understand what this molecule can do, and maybe others cannot do when it comes to control of the disease, whatever the stage, is it acute stage or chronic stage. So now we have a broader level of blocking. We have a comprehensive mechanism of action by the introduction of JAK inhibitor. Now, I think the future for the JAK inhibitor will be very interesting for us, will be completely different than what we have to use in the past, because the concept of blocking more than one key player, more than one cytokine, it definitely may add a benefit for the treatment paradigm of atopic dermatitis. And this will make a broader control of the disease, will make a fast onset of action of control of itch, will make a broad spectrum control of the chronic disease by blocking all these different cytokines.
Thank you, Dr. Ahmed, for this very illustrating response. And if I add something, I add, because most of the treatments we have it for those chronic, severely affected patients is just a reactive type of treatment. When the patient has flare-up, we are going to introduce a systemic treatment. But with JAK inhibitors, which is a continuous use, we are going to have a continuous suppression of type 2 inflammation, which have a very good feedback on other atopic comorbidities as well.
That is very interesting, Dr. Hussain, and Dr. Amin, you explained it pretty well. So from what I can recap from what both of you have spoken, we have reached a stage where we have an oral tablet which can be taken very easily by the patient, and it can improve itching and the quality of sleep at a very fast rate, and make a huge difference in the appearance and the quality of life. So it's indeed an exciting time. Thank you.
So now the second question about baricitinib, which is very important. I'm going to start addressing the question to Dr. Ahmed Amin. Dr. Ahmed, how do you evaluate the efficacy of baricitinib in atopic dermatitis from the data perspective and from your clinical experience as well?
Yeah, thanks, Dr. Hussain, for raising this point, because as we understand it, the difference between randomized clinical trial and real-world evidence is very important to differentiate how the trials have been done and how the selection criteria, inclusion criteria of the patient, exclusion criteria, it's a completely different story about what we are seeing in our clinics. You cannot refuse to treat any patients and say that it's not, your patient profile was not there in the clinical trials. We have to accept everybody in our clinics. However, not everybody was eligible for the study criteria. There is a specific washout period of topical steroid about 2 weeks, a specific washout period for the systemic steroid for 4 weeks, and this is what we not used in our clinical practice. So if we'll have a look in the data of baricitinib in atopic dermatitis treatment, especially the combination data with the topical steroid, they did a pretty good job. They have a close results, very comparable with what we have dupilumab treatment in atopic dermatitis. But if we go to our clinical practice, we even have better performance when it comes to the fast onset of action, the reporting of improvement in itch after 2 to 3 days, the clearance stage that we are achieved. So we have a good data when it comes to efficacy, when it comes to fast onset of action, but what we are seeing in our clinical practice is even better because we don't have these restrictions that we know about the clinical trials restrictions.
Thank you, Dr. Ahmed, for expressing your opinion. And again, the same question, I'm going to repeat it for you, Dr. Siri Kumar. How do you evaluate the efficacy of baricitinib from the from the perspective of the data perspective of the clinical trials, as well as from your clinical experience?
Dr. Amin has already expressed it pretty well. Clinical trial is totally different from real world experience. Clinical trials already have a lot of restrictions, and in real life, we face a different situation. So when you evaluate a drug in real life, we are interested in efficacy and safety. So when you combine efficacy and safety, we are basically talking about a therapeutic index of a drug. So when we talk like this, we understand that the trials have shown a pretty impressive efficacy, which have primarily been shown in investigator global analysis and ESC, which were the two criteria which were primary endpoints. In real life, obviously the quality of life of a patient, the ease of use, the safety, and the long-term efficacy and the sustainability of a medication is very important. So I would say that the trial data have been pretty impressive, and in real life, with the short experience that I have had, the real life experience seems to be even better than the trial data. Of course, we need the ideal patient, adult patient, moderate to severe atopic eczema who has failed topical therapy and requires a systemic medication. We need to make sure that there are no contraindications, and we need to do the tests required before starting the medication and monitor it properly. So once we understand how we handle this medication, I'm sure that the real life experience is going to be wonderful. So my short real life experience has been really rewarding.
Thank you, Dr. Siri Kumar. And after explaining and discussing the good effects of baricitinib in the treatment of atopic dermatitis patients, we have to consider another considerations. So my question now for Dr. Siri Kumar, what are the safety considerations that a dermatologist prescribing JAK inhibitors should be aware of?
Dr. Sen, you actually raised one of the most important points for us as dermatologists, and since this is going to be viewed by a lot of dermatologists who are interested in starting patients on Olumient, we need to be very clear and have a checklist. We need to know which patient is eligible for this injection, what are the contraindications which are absolutely there, and how to evaluate a patient before we actually start the patient on this medication. So let's be clear, Olumient as of now is licensed for 18-year-old and above adult patients with moderate to severe atopic dermatitis who are candidates for systemic therapy. So there are three important points here. One is an adult patient. Second is a clear-cut diagnosis of atopic dermatitis. We all know that you can miss a diagnosis. You need to be very clear and sure that we are dealing with a case of atopic dermatitis with the adequate criteria. And third is that they should be candidates for systemic therapy, which means that they should have already used topical therapy and either failed to get an improvement or have a intolerability to topical therapy, and they must be definitely candidates for systemic therapy. We all know the conventional systemic therapies and the challenges that we have with them, and many of the conventional systemic therapies have lot of issues, including drug interactions, monitoring, etc. The classical example being cyclosporine. But with baricitinib, the main thing is that once we are sure that we have an adult patient with moderate to severe atopic dermatitis as defined by many of the criteria which are accepted, the insurance probably will accept an investigator global analysis of 3 or 4 severity or an ESC, which is at least 16 or above. So we have clear-cut definitions of what is moderate to severe atopic dermatitis. Make sure that we have these criteria met before we start the patient. Second is we should document clearly that the patient has used other medications and has not been successful, especially the topicals, either not successful or intolerant. And this is shown by the frequent flares and the quality of life of the patient. So we need to document the DLQA definitely. Once we are through all this, we need to have a checklist to make sure that we don't have a patient who is a contraindication. Definitely not a pregnant lady, definitely not somebody who is going to breastfeed, definitely not somebody with a Wells criteria for high chance of getting a DVT or a pulmonary embolism. We do a pre-treatment workup, a complete blood count. We have to make sure that the absolute neutrophil count and the absolute lymphocyte count are adequate. The hemoglobin is not less than 8. And even a lipid panel needs to be evaluated 12 weeks down the line after we start. So baseline, we need to make sure the patient does not have any infection. So an active tuberculosis is a contraindication. A latent tuberculosis, we need to make sure that the patient is on treatment before we can consider baricitinib. Hepatitis B, hepatitis C, active infections, all need to be factored in. So with all these investigations being done and checklisted, we get a patient who has an indication, who has no absolute contraindication, and who has all the safety data inputted in the form of the blood tests being done. Once we reach this stage, obviously we have a candidate for an oral medication which can have life-changing results.
Thank you, Dr. Sri Kumar. And I'm going to address the same question to Dr. Amin if you have something to discuss with us or show us, please.
Yeah, I completely agree with all what Dr. Sri Kumar summarized regarding the safety consideration of Olumient in atopic dermatitis patient. But if I need just to add something, that we are not talking about new molecules in the era of treatment of our immune-mediated disease, because Olumient have been used in rheumatoid arthritis for 8 to 9 years now. So we are talking about a molecule that was well established. We will come to know 100% which patient profile will be eligible for baricitinib for atopic dermatitis. So we know from the long-term safety data that published in rheumatoid arthritis patients. However, we are completely agree that this is completely different patient profile with lots of associations, with lots of different comorbidities than atopic dermatitis, but still Olumient is doing a very good job when it comes to the safety in these such patients. So as Dr. Sri Kumar summarized it, all the patients with an active infection, with an active TB, with a high risk of hepatitis, with have some abnormal laboratory finding when it comes to hemoglobin level or neutrophilic lymphocytic count, all these patients are better to avoid the use of all the class as a JAK inhibitor in treatment of atopic dermatitis.
In connection with that question, there is a hot topic about the newly published FDA safety updates about JAK inhibitors. Do you have any comment about that?
It's a very critical point when it comes to the FDA warning, which started for the tofacitinib. So if just I will summarize it in a very few minutes. Tofacitinib have been approved in rheumatoid arthritis since 2012. And after some safety consideration, the FDA started to raise some questions in 2014 about the long-term safety data of the tofacitinib. So they started the oral surveillance study in a specific types of rheumatoid arthritis patients for the tofacitinib treatment. And if we'll go back to this trial, we will see that the inclusion criteria was very restrictive. We have patients more than 50 years old with one at least cardiovascular comorbidity with a moderate to severe rheumatoid arthritis. Based on this trial in this specific population, the FDA started to raise this warning that we should not, we should be aware that the JAK inhibitors have some problem with the safety issues and the issue, the black box warning. In that time, tofacitinib was alone, was talking about the JAKs as a class, the ban JAK, which is blocking all the JAKs, JAK1, JAK2, JAK3, and TYK2. So the FDA warning was for the tofacitinib in moderate to severe rheumatoid arthritis patients who is aged more than 50 with one or more cardiovascular risk.
Very well put by Dr. Amin, sir, and you raised a very important question actually. You can't compare rheumatoid arthritis and atopic dermatitis. This is not comparing apple to apple, this is apple to orange. So the patient profile of rheumatoid arthritis is totally different, as Dr. Amin tried to say. And you are comparing, again, a different molecule. We know that Xeljanz or tofacitinib is a pan-JAK inhibitor, whereas baricitinib or Olumient is a more targeted molecule, which specifically targets JAK1 and JAK2. So neither is the disease similar, nor is the patient profile similar, nor is the medication the same. Therefore, it's not possible to compare these two head-to-head as far as this particular concern is concerned. Of course, time will tell us. We all are responsible physicians, and we need to monitor our patients. But I would say that this is not a concern as of now. As we all know, the most common side effects are upper respiratory infections, folliculitis like acne, and simple things. The major serious side effects, including DVT and pulmonary embolism, are extremely rare, as the trials have shown. So I would say that this is not a straightforward comparison.
Thank you for the explanation. And the key point here are that we are not comparing the same issues at the same time. Okay, my next question, and I'm going to start with Dr. Ahmed, about are there is any specific considerations that dermatologists should be aware before starting a patient on baricitinib? And do you usually consider the same investigations before any biologic agents among those group of patients?
If we're talking about the monitoring test or investigation before starting the treatment, the biologics is a little different than the small molecules like JAK inhibitors. So what we are doing with the JAK inhibitor patients is what we used to do in the psoriasis biologics, that we need to exclude any active infection. So gamma interferon TB test should be done before the treatment, hepatitis B, hepatitis C. We have to do complete blood count to be sure that hemoglobin level, neutrophilic count, lymphocytic count is within normal. Maybe we need to do lipid parameter to know the baseline readings, because lipid parameter, one of the parameters that we should follow maybe every 12 weeks. So we need to know where we stand before the treatment. So monitoring tests should be done before starting the treatment, same as what we are doing in psoriasis biologics, but maybe it's not the case with the biologics in atopic dermatitis that we are not used to do any monitoring test. Related to that, before initiation the treatment of JAK inhibitors, and specifically Olumient in atopic dermatitis, as we can see in the slide, yes, we need to screen for the TB test, for the viral hepatitis. We need to know the venous thrombosis risk for the patient. We need to know if there is any active infections going on or not. It's recommended for the patients to finish any immunization program before starting the treatment, because some of the live vaccines should not be administered during the treatment course. We need to consider starting a latent TB prophylaxis therapy before the treatment at least 4 weeks, and then after that we can start our JAK inhibitors. We should not use JAK inhibitors in specific types of patients during the pregnancy. Lactation, we don't have a clear data about that. Patient with active TB, patient with active serious infection, patient with have a significant liver and hepatic and renal impairment. We should not start JAK inhibitors in such patients. We need to use with a caution with a patient who have a high risk of pulmonary embolism or DVT. We should not combine JAK inhibitors with other medication which have an immunosuppressant action. We should not use both drugs in the same patient. During the treatment, we should discontinue if we start to see any evidence of pulmonary embolism or DVT. We should interrupt the course of the treatment if we got any active acute infection like herpes zoster or serious infection, if we have any doubt of malignancy, if we have any hematological abnormalities came to us. So all this, we should interrupt the treatment. And in the end, we need, as per the EMA label, we need to monitor the lipid parameters once every 12 weeks. So I think this is a summary what we need to know before starting Olumient treatment of our atopic dermatitis, which alarms we need to keep our eyes open to watch our patients. We need to be sure that our patient profile is really eligible for the JAK inhibitors, because as we learned it for the chronic treatment of our patients, we need to make a balance between the efficacy and safety. We need to treat the patient as a one package. Yes, we need an effective medication, but definitely we don't want any non-expected safety signals. So we need to choose the right treatment for our patient based on the balance between efficacy and safety.
One of the interesting things about baricitinib or Olumient is that it has got a very short half-life. And it actually is a small molecule which reversibly binds to the ATP site. So it has got a short half-life, it's reversibly bound, and therefore I would say that if you look at the pharmacokinetics and pharmacodynamics, it is primarily excreted through the kidney. Less than 10% goes through the liver. Therefore, it's one of those molecules where interactions in the liver are much less. Of course, the eGFR below 30, we should have some concern. Elderly patients above 75, we need to have some concern. And like Dr. Amin said, if the patient is on other medications, I believe in rheumatoid arthritis, they do combine it with methotrexate. But if there is any other medication being given, we need to be aware. In fact, in rheumatoid arthritis, there is some concern about diverticulitis also. Patients with the history of diverticula, especially if they are on NSAIDs or on steroids or on opiates, there are some reports of diverticulitis. So abdominal pain, fever, vomiting, anything happens in a patient on Olumient, we need to take care. But otherwise, I think Dr. Amin has beautifully summarized everything already.
Now, Dr. Sri Kumar, I want to ask you a very important question to know your opinion about it. What are the advantages of using baricitinib in cases of severe atopic dermatitis compared to other available treatments?
A very important question, sir. In fact, I would say that as dermatologists, we all have this cafeteria choice now. Obviously, we all have a large number of patients with eczema. We have a large number with moderate to severe eczema with a huge impact in quality of life and cost of care. So do we go for phototherapy? Do we go for conventional systemic treatments like cyclosporin or the other immunosuppressives? Obviously, they all are having a lot of side effects, drug interactions, and cyclosporin cannot be used for a longer period of time. Now, do we go for the newer medications, the newer biologics, obviously dupilumab being the oldest among them, and a plethora of new JAK inhibitors and biologics coming up for atopic dermatitis. Now here, we know that the care of atopic dermatitis is a shared decision making. How do you do a shared decision making? You have a counseling session with the patient, sometimes with the parents in pediatric patients, but since Olumient is only for adults, it's primarily a shared decision making between an adult patient with moderate to severe atopic eczema with a clear-cut endpoint. What is the patient's perspective? What does the patient want? Does he want the itching to go? Does he want the sleep to be better? Does he want his or her appearance to be better? Does he want to go for a certain education or occupation and be better, reduce absenteeism, presenteeism? The goals of the patient have to be defined. Similarly, our goals as a dermatologist should be defined. So when you combine all these and offer all the medications available, you tell them that you have an oral medication now, which is indicated, which can reduce your itch in a very short time. By the second day itself, itching is gone. And we tell them that, look, not only is itching gone, but your sleep will be better, your skin pain will be better, you will have a good improvement in your appearance and quality of life when you show them all this. And of course, we always talk about the other molecules also, the fact that we have a good plethora of choice. And then we tell them that, look, don't worry too much about the safety. Of course, we give them a patient information sheet or booklet about the contraindications. We make sure that we don't choose patients who are likely to become pregnant or breastfeed, or patients who have a renal impairment with a low EGFR. Once we have a clear-cut patient who is eligible for the medication, we tell them that, look, you have an oral medication, you have injectable medications, you have medication which produces excellent results very fast and which can be used for a long period of time, which are sustainable, which has a track record. And then we let them choose along with us. We assist them in this. My own patient experience has been wonderful like this. I've had, even recently, 2-3 days ago, I had a patient whom I counseled about taking dupilumab injection and oral JAK. This patient was on a short vacation from India, and the patient was actually traveling to and fro. Just imagine if you suggest an injection for this patient, it's not that easy. Even now, dupilumab has to be taken in an office setting. I know that auto-injectable pen is available and soon the patient may be able to take it. But at the same time, it's an injection after all. Whereas you have a tablet in offer which is easy to take. And the patient herself, in fact, chose an oral tablet. So it's a shared decision making. Each patient is unique, is different. And every patient has to be counseled thoroughly with the pros and cons. And decision making is a shared decision making process. Thank you.
Thank you. Dr. Ahmed, how do you see the advantage of using the baricitinib when compared to other systemic treatments in cases of severe atopic dermatitis?
Yeah, first of all, I have to agree with all Dr. Sri Kumar said. While we are evaluating any new drug, we are evaluating in some parameters. We are seeing the durability of this medication, the efficacy, the sustainability, the safety, the simplicity as well. So if we put Olumient in front of all these 4 or 5 domains, we will come to know where we can position Olumient in treatment paradigm of atopic dermatitis. When it comes to durability, we have a significant itch control within days, which is, we don't have it earlier before with the current treatment that we have for atopic dermatitis. When it comes to efficacy, we have a good curves and acceptable results. Within few weeks, we have sustainable results up to 1 year data that we have it now. When it comes to simplicity, we are talking about oral route of administration, which is easy to start and easy to stop. We are talking about half-life of few hours. That means that the 5 half-lives of this medication is just a few days. So the patient going to be pregnant, the patient want to take vaccine, so it's not a big deal with them. When it comes to safety, we have an accepted short-term safety data. And the very important point in the safety data that we don't have a cumulative dosing safety concern or dose-dependent safety concern. The safety concern that we found in the 2 milligram is the same as 4 milligram. We have a long-term safety data in rheumatoid arthritis patients for so many years. So we are talking about a profile for this medication that really can position Olumient as a first-line systemic therapy for our patients due to this advantage. We don't want anything else for our patient. Once we have a medication will meet this criteria of durability, of efficacy, of good safety profile, of sustainability, of simplicity, and in the end, as Dr. Sri Kumar said, that sharing decision with our patients is a very important point based on the concerns of this patient specifically. Some patients really one day will matter when it comes to the quality of life impact. So we need to improve the quality of life within days, not within weeks or months. So while we are understanding the patient profile, we will come to know how to pick the best treatment for such a patient.
So you mentioned already my next question about how do you see which is the most patient who can have the most benefit of baricitinib?
Yeah, based on the data that we are seeing that days are matter in these patients, any patient need a fast onset of action will take a very important benefit from Olumient in atopic dermatitis treatment. If we have a patient with a really quality of life impact, which is significantly affected, and we need to save his skin from all these problems, definitely we'll find the answer of this question with the JAK inhibitor. While we are introducing these molecules, we are highlighting a new concept that we are offering to our patients a new life, not only new skin. We'll start to look beyond the skin. Yes, as a dermatologist, our first concern is the skin clearance. But while we are understanding our patient, we see really how the quality of life have been affected to our patients, have been implemented due to the bad disease. We will come to know that fast onset of action for this medication is a very important concept. So the patient who have a non-stable flare, patient will have a severe disease, patient will have a non-disease-free period, patient will have some maybe planning for the pregnancy in the near future that we need, as I told, easy to start, easy to stop. We have some patients really have an injection phobia that they cannot take injections. We have patients, they didn't accept the treatment as an injection for the last few years because there is no other available options. But now we can offer our patients multiple options. Once we, based on the safety concern that this patient is eligible for all these medications, we can share the decision. The patient can pick the oral tablet if it seems to be the most effective and medication that can be compliable with. So all these parameters will take benefit from Olumient treatment in our atopic dermatitis patients.
So, Dr. Sri Kumar, did you see which patient?
Wonderful, sir. It's been a wonderful discussion. We all know real life. I see patients who have an exam in 2-3 days. A young person, a college-going individual, an adult, having to face the most important examination in their life with a massive flare of atopic dermatitis. We see people who say that they have to actually go for a date. I know young women with severe eczema who couldn't get married, who need to actually go to meet their future husband. And we have had patients who actually are in the process of getting married and want to have a great honeymoon. And we actually are very much in need of an effective agent, which is easy to use, easy to take, and produces really fast results. The fast result of Olumient is a big blessing. And of course, the overall impact on the quality of life is very, very important. Therefore, we know that Olumient is a medication which can be used not only for a flare suppression, but like you yourself started the conversation, as a proactive treatment, not as a reactive treatment, to give the best quality of life over a long period of time. So Olumient has many of these check boxes ticked.
So most patients of severe atopic dermatitis can have a benefit the most from baricitinib oral treatment. So now, after discussing the molecule, how it works, what are the data from clinical trials, from real-life experience, what are the common side effects, how we are going to prescribe the medication, how we are going to start, what are the monitoring guidelines, we are going to do it, who are contraindicated, who are not eligible for the treatment, we come to very interesting part. After all this, we talk as physicians. What's the patient's feedback about using such a molecule? Dr. Sri Kumar, please, and sharing cases is very welcomed as well.
It's time for us to transcend from the book to real life. And it's time for us to actually experience this molecule in real life in our patients in the office setting. So let me start with my very first case. This is a young lady who is around 20 years, and she has been having eczema from the age of 18 months onwards. We all know eczema has a different endotypes. You have most of them, 60 to 80% start early life, within the first 2 years of life. You have an early onset, which subsides by the time they are 2 years or 5 years. You have an early onset with frequent flares, which go on and on and on for a long time. You have a late onset. You have different endotypes. I'm not here to talk about all that. My talk is mainly on this patient. She had a fluctuating course, and she had been having treatment for asthma too. Now on, then she had been on puffs. Her sister had eczema, maternal grandfather had asthma, a typical atopic family. And she had used topicals for a long time as a child and homeopathy. The biggest thing with her was that she was fed up. She was frustrated, depressed, nothing was working. Her parents said, you are becoming worse because you ate this, you ate that, you did this, you did that. Her bath was a nightmare. She was having a horrible time indeed, and nothing seemed to work. And this is how she looked when she came to me. You can see the clear-cut distribution, the classical morphology of the eczematous lesions with redness and scaling. And the decision point was a 20-year-old lady, severe exacerbation, especially from the time she came to grade 12 board examinations. She was frustrated. Every exam was a nightmare for her. She said that I am in the most productive period as far as my education is concerned. Now I am in college. And when I saw her, her body surface area was 20, which is a severe case. It's not a mild at all. ESC is 32.8. The PGA is 4. The square is 72.05. The poem was 28. Her quality of life score was 21. You know, anything about 20 is a horrible quality of life. I can't imagine a person having a DLQA for 21 for a long time. And the anxiety score was 13, and the depression was 8. So we have a severe atopic dermatitis, a classical atopic dermatitis in a 20-year-old with no response to standard topical treatment. So you have a clear-cut indication, a severe atopic dermatitis, an adult patient, and the topical therapy had not worked for her. There's a need for systemic treatment. What were the important goals for the patient? She wants to go for an exam. She wants the itch to go fast. She wants to look better. She's a young lady. She needs to interact with her colleagues. She needs to develop relationships. So with all these goals in mind, I decided that this would be an ideal candidate for Olumient. I had discussed with her a shared decision making, and we actually put up a chart. We said we offered phototherapy. It was impossible. Just imagine a person coming for phototherapy 3 times a week being an exam-going student. It was impossible. We told her about cyclosporin. She definitely did not want to take a chance with her kidney. And we told her that many of the other conventional systemics take a long time, and only high dose and over a long period of time you may see an improvement. She needed a fast improvement. And she didn't have the time to come to my clinic to take injections, and she was not keen on injections. So obviously, this was the right candidate for Olumient. Her TB gold quantiferon was negative. She didn't have any active infections, hepatitis B or C. The counts were normal. The liver function test was okay. Her kidney was okay. I put up a Wells probability score for her for DVT, which was 0, and for embolism also, pulmonary embolism was also 0. I started her on baricitinib, 4 milligrams once a day as per label on 15/4/2021. And you can see that what happened to this frustrated, depressed lady in whom nothing seemed to be working. She obtained a rapid and significant improvement. Her itch NRS and sleep NRS showed a rapid, minimally clinically relevant clinical difference as per the parameters. There was a rapid improvement in her quality of life, a significant improvement in lesion extent and severity, and it was well tolerated. So let us see. If you talk about the itch and the sleep score, see, this is actually over a period of 8 days. Within the first 8 days, the itch NRS was 9. Believe me, most of the trials show 7. So her itch NRS was 9 when we started. And within 1 day, it became 7. And within 2 days, it became 4. See, within 2 days, you have established more than a 4-point difference in the itch score. Similarly, the sleep NRS was 8, and it came down to 5 within 2 days. And within a week, it almost became 2. So a major improvement in EASI. EASI is the Eczema Area Severity Index, which is basically an appearance. You see the appearance score, which was 33, became 6 within a week. A huge drop. The SCORAD, which combines the appearance with the subjective symptoms, which includes your itch and sleep scores. And from 72, it became 26. The global assessment from a very severe case, 4, it became 1 within a period of 1 week, which was amazing, which I had never seen earlier, maybe except in cyclosporine cases sometimes. And I had done an ADCT, atopic dermatitis control test, and it showed a very, very significant steep improvement. Her HADS anxiety score again fell down to 2. Depression became 2. She became very confident that we now have new molecules which will produce a huge difference for her. And the quality of life also improved hugely. These are my after pictures showing you the huge difference, and this is a before and after comparison. The photographs don't tell the full story in eczema patients. It is the sleep quality, it is the itch severity, it is the appearance, it is the confidence, it is the kind of clothes they wear, the kind of activities they involve in, the kind of food they take. It's a whole different ball game. And of course, the associations with the other type 2 conditions like the food intolerance, the asthma, the sneezing, they're all champion sneezers. It makes a huge difference in that. And we actually are very much interested in finding a drug which is actually used once a day with rapid improvement in almost all the parameters with well-established safety profile and which can be used over a long period of time. And I would say that my first case was a really rewarding experience indeed. Of course, this is for you. Once you do experience, I would say that it's for you to tell us whether you feel very confident to start this medication, you know how to select your patient, how to filter for contraindications, and how to manage these patients. And the whole objective of this talk is to improve the quality of our life of our patients and offer them a medication which is easy, simple to use, and life-changing.
Thank you, Dr. Siri Kumar, for sharing this, your first case of baricitinib in severe atopic dermatitis. It is very well illustrated the maximum or the big difference between before treatment and 1 week after treatment in all parameters.
Thank you very
the
much.
Physical, the psychological, the quality of life, the itching, every parameter which are the main factors for systemic treatment in case of atopic dermatitis. Thank you for sharing this case, which is really, if I have the chance to respond to your question, I am very confident to use it. After sharing this nice case with Dr. Siri Kumar, we are going to share another case, one of the difficult cases of severe atopic dermatitis, which has been treated by baricitinib with Dr. Ahmed Amin.
Thank you, Dr. Hussein, to give me the chance to share my clinical experience with Olumient in atopic dermatitis patient. So if I start with the patient profile, we are talking about 21 years male patient. He's a student in the college, and his atopic dermatitis history started at the age of 16 with 5 years history of moderate to severe atopic dermatitis. For the last year, the patient have reported a monthly flare of atopic dermatitis. When we try to assess the patient, he have an EASI score 8, SCORAD score 10, body surface area 8%. Itch score have been reported as a 7 out of 10. Patient was reporting a significant pain and soreness and discomfort, and patient was having a significant involvement of difficult to treat areas, which is hands, The DLQI impact was reported as a 25. And I want to stop here for a minute because which patient is considered severe patients? We are using this assessment tools to know where we stand. EASI score as an 8, SCORAT as a 10, body surface area as 8%. In these three parameters, we can categorize the patient as a moderate patient. But once we're having a localized lesional severity, like hand is atopic dermatitis, which has had a significant impact of quality of life, as the DLQI has reported as a 25. So in that time, we should not respect all these assessment tools. DLQI is enough for us to categorize this patient as a severe patient, even he don't have an extensive disease. So that's a very important point to understand which patient for which therapy, because in that time, if I stopped in the EASI SCORAT body surface area as a moderate patient, maybe I will pick phototherapy, I will pick topical treatment. But once we have another parameter, which is highlighting the quality of life impact in this patient, so I have to up-categorize him, I have to treat him aggressively to save the quality of life impact that he achieved. Patient was not having any association of other atopic marsh comorbidities. He unfortunately had frequent attacks of skin infection due to secondary bacterial infection from the frequent itching. Definitely all these contribute together for some psychological comorbidities in a very simple way, in very simple term, as there is no any self-confidence at all because of the exposed areas of atopic dermatitis, which is hand eczema. So that's the patient before the treatment. We'll come to know that there is a significant affection of the hands. Yes, he don't have a generalized disease. He don't have an extensive body surface area. But patient have a critical symptom, which is hand eczema, which is making him embarrassed all the day while we are dealing with his classmates, with his colleagues. They will look to him in a disgusting way. Is this disease considered as an infectious disease or not? So it's really, we need to consider these points while we are treating our patients. So patient have a lesional severity in specific areas of his body, which is making a direct impact on his quality of life. Patient fed up with the creams. He used topical steroid creams for a long time. Calcineurin inhibitor, tacrolimus have been used. There is no significant control. Patient do not have a disease-free period because of the hand eczema. The topical steroid will do well for quite some time. Then once it's stopped, again it will start flare, so the patient cannot be sustained on topical steroid forever. He tried hand and foot phototherapy. For some times also, there is no proper control. There is no history of systemic treatment because of this misconception that no other doctors offered him a systemic treatment because they are considered him as a mild disease due to the low body surface area. So that's the main message today, that we need to understand what severe patient means, not only extensive disease. We need to look to our patients as a one package. Quality of life impact is a very important parameter to be considered while we are classifying our patient. So patients start Olumient treatment, 4 milligram as per the licensed dose. Investigation have been done as per the label and as per the guidelines to exclude any contraindication to start Olumient treatment in such patient. And now we will come to know what Olumient did for such a patient in only 4 weeks. We are talking about a different level of clearance in a short time. So severe recalcitrant hand eczema in a patient with a significant quality of life impact have been cleared within a few weeks. And now we can imagine what we did for this patient, what a great job Olumient did in such patient, and definitely what a positive impact have been achieved in his quality of life due to this high level of clearance. So the patient is completely cleared within few weeks. As we can see, there is a different story. Again, I will go back to my concept. We are offering a new life, not only new skin, with these new molecules which can control our bad disease dramatically. So I can share that this is one of my best experience in treatment of my atopic dermatitis patients, because patient reported an itch improvement from the 3rd day, and this is very big achievement. We don't have this history before in the past with the available conventional or even systemic therapies for atopic dermatitis. Patient reported a skin clearance as a 5 out of 10 within 1 week. So it is just a few days to achieve such a high level of clearance. Patient reaching an 8 out of 10 clearance after 2 weeks. There is no any signs of skin infection anymore. Patient stopped topical steroid after 1 week. And this is, again, the advantage of using such a medication, which can make a complete control of the disease, that we will not need to use topical steroid on a daily basis as we used to do before. So that's my experience with Olumient in such a difficult patient, and I can assume that this patient, we offered him a different way of clearance that he not used to have before, in a simple way, with a convenient dosing, in a very simple route of administration, and that's what we need for our patients today. Thank you very much.
Thank you, Dr. Ahmad, for sharing this very nice illustrated case as well. And thank you as well because you emphasize a very important point. We are treating the patient, we are not treating the eczema only. So those patients, it's better to be classified that are eligible for topical treatment or for systemic treatment. Of course, these parameters, we have to do it to measure the severity and to measure how those patients have been improved after treatment. But it is not only the physical part of the disease. Those patients may be, as you clearly show to us, that in spite of the low physical part or the small percentage of cutaneous involvement, but this disease has a severe impact on the quality of life. That's why we are treating the patient rather than the atopic dermatitis. Thank you for emphasizing this. And systemic treatment is not only for, I do prefer not to classify to mild, moderate, severe, better to classify those patients for topical treatment or those patients need systemic treatment. Thank you, Dr. Amin. Now, after this very nice discussion about many phases of the newly introduced molecule of JAK inhibitor, the baricitinib, I would like to thank my colleagues, Dr. Siri Kumar, Dr. Ahmad Amin, for this fruitful and beneficial discussion. Really, I am very thankful for both of you. And now, let us hear from the audience what questions they have.